Good afternoon, everybody. Thank you for joining us. Welcome to the Siemens Healthineers Lunch Symposium. My name is Matthew Fold. I'm the Director of Photon-Counting CT here in North America. So it's great for you to come and join us, hear about the real-world results with Photon-Counting CT in cardiac. And we've been talking about this now for a number of years. 4 or 5 years ago was what we talked about in novel technology session, and last year we presented real results from some of our early users, and it continues to grow. So we're excited to have 2 great users here to talk about their experience. Before that, I will just do a very brief introduction to what photon counting is for those of you who have not been paying attention at the meeting for the last day and a half. But it's great to have you enjoy lunch. We will do our best to save some time for questions at the end, but if we run out of time, please come up and join us and ask questions afterwards. So again, thank you for joining, and let's get started. The onus, the onus for CT, the reason we do it is really 3 main things. It's high spatial resolution. That's the ability to see details, coronary plaque, the walls. Without spatial resolution, we don't really have cardiac CT, but it is a balance between resolution and radiation dose that we always have to deal with to figure out what you get. We also need to image the fastest moving organ in the body. If you can't stop motion, then it doesn't matter what spatial resolution you have because it's blurred out. And if you are a CT user and have been exploring in the last, say, 15 years, you've been looking at expanding beyond morphometric imaging to function or composition, spectral imaging, dual energy, whatever you want to call it. There have been systems over the years that could do each one of these things reasonably well. High resolution, but slow. Spectral imaging, but slow. Or any other combination. The benefit of photon counting in a dual source CT, which is what we're talking about today, is everything is all together, all at once, every time. And really, we can use that to huge advantage in cardiac imaging. A conventional detector is based on light. X-rays hit, create light. We measure the light. There's a lot of weaknesses through that. Energy information is lost. Dose is harder to control because you waste space on the detector. With photon counting and a semiconductor crystal, X-rays are directly converted into a signal. We can use all of that information to really expand what you can get. Again, spectral information, high resolution. And we can go beyond regular high resolution and really push the boundaries with an ultra high resolution mode, what we call quantum HD cardiac, allowing us to go down to 0.2 millimeter thin slices, really pushing the boundaries of resolution that we can do in such a fast-moving organ. And so it's not just spectral, it's high resolution, lower dose, spectral with better contrast, all at the same time. And we do that with the advantage that Siemens is known for, temporal resolution. It is a dual source CT with the same speed and power as a somatome force that many of you know and love. So 66 millisecond temporal resolution, 74 centimeter per second volumetric coverage for single heartbeat imaging, any patient, anytime, and now with any underlying plaque characterization, because we can do it, whether they have a stent or not. We can do it because of the combination of what we call quantum technology or photon counting and dual source CT. So it's truly a unique proposition in the market. Siemens is the only vendor offering this type of technology, and we're very proud of it. We're proud that it really unlocks new impressive details that you can see by eliminating calcium blooming, by allowing you to visualize within stents. We can use spectral imaging effectively inside the coronaries that are moving so that we can eliminate a calcium signal and only focus on the iodine. We can do all of this only because of the unique combination of this technology. And you can see a couple of very simple example images here. The physicians will show theirs in greater detail, but the difference between what you could expect before with 0.6 millimeter now with 0.2, you see it in plaque detail and plaque delineation, what was smudgy before is now crisp, detailed, the separation of hard and soft plaque. So think about using this towards plaque analysis. Whether you have implantable devices like stents, can you evaluate them with a coronary CTA instead of a visit to the cath lab? And we know that you can. And there are great papers that have even recently come out with numbers and more coming out demonstrating the value of this technology. So we appreciate all of the researchers and early adopters of this technology really demonstrating what you can do, because it's the combination of all of these technologies that allow you to take a simple scan like this and eliminate the contrast, or take a scan like this and eliminate the calcium, really opening up the boundaries of what you can do so that we can change practice. And it is even tied to things that we've come to know and expect, things in guidelines like FFRCT. We can apply these new technologies to FFRCT and even change it. So if you, on the left, see a conventional image with the calcium intact, in the middle, one where we've virtually removed the calcium, and now the FFRCT and the invasive cath align even better. And so using these technologies is quite remarkable. Sounds very complex, photon counting, I'm talking about measuring direct. We've simplified and made it very easy and automated, a system driven with automation and AI. What we call My Exam Companion automatically chooses scan protocols, reconstructions, timings. It makes it simple and easy to implement and gives us the confidence in this type of statement that in the future, every CT will be a photon counting CT, and certainly I hope it'll be a Siemens photon counting CT. So a very quick introduction into the technology. Again, thank you very much for joining us. We have two really great speakers, Dr. Omar Khalique from St. Francis in Long Island, and Bálint Szilveszter from Semmelweis University in Budapest. So we're really excited to have them, and I will turn the floor over to Dr. Khalique to share his results. So thank you.
Sorry, I took a bite of cookie at the wrong time, then I had to start presenting.
It's a good-looking cookie, right?
I couldn't eat the chips, though, because they were too loud on the microphone. So I'll start with a story. So this is my first Siemens scanner ever that I've had. So I've always been on a volume scanner, both at Columbia for my 11 years there, and then starting at St. Francis. So we replaced one of our old volume scanners with this one. So we've been using it for a few months since January. So we've done about 3,000 cardiac cases since then. And last week, there was an issue with the injector for the Siemens. And when I was reading, and I had to use, we had to do the coronaries on a different CT scanner. And I was very depressed. I wanted to switch my reading day to a different day because for coronaries, the imaging is just so clear. It's hard to look at a lot of other stuff after that. So we were lucky in January to be the first site to get the photon counter as a dedicated cardiac scanner. So we do about 30 cases a day. It's our workhorse scanner at our main center for cardiacs only. And this is just first month's data, but there was an immediate impact. This was without training when we were just getting our protocols ready. If we counted the overall number of indeterminate segments read by the team, they decreased immediately from 18 to 11%, and they're continuing to decrease into the single digits. So I got the easy job of not talking about much technical stuff, but just showing cool pictures. So Matt and Bálint are going to do most of the technical work. But I just want to show a couple examples of what we're doing. So we have a protocol for us to switch to quantum HD cardiac, which is the ultra high resolution mode for either high calcium cases and then also for stent cases. So this is an example of a total calcium score of 908 and a single artery score of 508. And as you can see, there's absolutely no issues with reading through this calcium. Very minimal blooming in this long segment and easily read as a non-obstructive stenosis. Now, this is a case with two prior stents, and we can nicely see the stent anatomy. And I'll show you different kernels, which are listed here throughout the reconstructions. So this was a quantum HD cardiac at 0.2 millimeters. It was an iterative reconstruction of 3, which is kind of the average, and an intermediate kernel, BV56. And we're able to see things very well. Here's another example where the blooming, for whatever reason, was a little more, or the stents were thicker. And here we still used the quantum HD cardiac because it was a stent case. But here we used a sharp kernel, BV68, which I'll talk about a little bit shortly. But again, very easy to read through these stents. And probably some people are wondering about the stent sizes. So I think we've definitely done 3 millimeter stents and read very clearly into them. I can't remember if we have any below that. Maybe Bálint will tell us if he's seen any, but definitely 3 millimeters, we're able to read through them. So here's an example of actually multiple stents, and in the area that's outlined there, there are overlapping ones. But what you can actually see as well is that not only can we see the stents, but we can pretty clearly see that these stents were deployed within calcified lesions, and we can see the calcium external to the stents. So this is a very good description of the morphology here. And this is, again, quantum HD mode, 0.2 millimeters with an intermediate kernel, and iterative reconstruction of 3. So one thing that other users of force and other scanners have told me that sometimes with the very sharp kernels you'll get higher image noise, which can preclude some of the interpretations. So here I'm just showing an example going from a BV44, which is a smooth kernel, all the way up to BV68, which is pretty sharp. And what we've found is that there is some image noise, but in cases where we need to decrease the blooming or make stents sharper, we're able to easily read through the noise, so the noise is very adequate. So we can use these different reconstructions to help us. So this is a very recent case, just from a couple weeks ago, some type of preoperative clearance. And what we see here is a quantum HD mode again, to ultra high resolution. And what we did was we used a smooth kernel at an iterative reconstruction of 3. And you can pretty clearly see the stent there with some mild in-stent restenosis. And what we also did was use a very sharp kernel, BV68, with the highest iterative reconstruction, which can sometimes get rid of the image noise. And in the sharp kernel, you can see that actually the stent becomes even a little thinner. You can see more of the soft plaque, and you can see the stent components, the little struts. And on the right-hand image, what we also see is that there are soft plaques at the edges of the stent, so either those are new or maybe they were perhaps missed during the initial deployment. No, sorry. Let's see if I can get it. There we go. So this is a different vendor. So these, I think most people would consider this to be a pretty good quality scan overall. No noise really, still motion, good contrast. But when you look at the stents here, you can see a clear difference, right? I think these are average size stents, but these ones we can't competently see through the entire tree of the stent, and much more difficult to diagnose. Another very practical use, so we've so far talked about quantum HD, so ultra high resolution, which is an excellent feature of this scanner. But one of the practical uses that we found for the spectral data is to, quote, save some low contrast TAVR studies. So our interventionists commonly order these, and they think it should be easy for us to do. But we all know the challenges. So sometimes we get lower contrast than what we had imagined. So here is the original reconstruction on the left at 70 kVs, and then post hoc, just on the single via system. I moved this down to 40 keV monoenergetic, and it's a very bright image. So here we're organically increasing the brightness of the iodine, which is very different than just windowing and making everything brighter. So we've done this on a number of the low contrast cases, and we end up with very good image quality. So you'll see this start to play in a second. This is the same patient, the TAVR CT. So I don't think, unless I told you, you would ever imagine that this was a 30 cc TAVR CT, right? And we're just going through the whole cine, moving our MPRs around. And you can see, for the purposes of TAVR, it's an excellent image for any type of left-sided analysis. So here's a comparison of just a cine from a case from the alpha on the left and another vendor on the right. And what you can see is just a demonstration of the temporal resolution. You can almost imagine seeing the blood flow. The contraction of the chambers is very smooth rather than choppy. And you can see a bicuspid aortic valve with severe calcification. So speaking of stents, sometimes we deal with much bigger stents in the form of TAVR. There are also things to see here. So this is a patient with a prior TAVR being evaluated for a TAV and TAV, so putting another TAVR inside of it. So the level of detail we can see here is actually quite high. So you see at the blue line, this is an evolute valve. We can see the nodes without the skirt, right? There's nothing in between the nodes, so these are open cells, so not an area where you can obstruct the walls. Then down below, what we see is, at the green level, is the nodes with the skirt, so the dark part is the sealing skirt, also outlined by the red there. And that's actually the part where if that skirt rides up into the sinotubular junction, you would be concerned, if you put a TAVR in, about obstructing the entire sinus. And then furthermore, we can see the leaflets quite well, and we can model what it would look like if our leaflets were then plastered against the wall, which is what will happen with a TAV and TAV. And we would be concerned here actually about left and right coronary obstruction via sinus sequestration. So this would be a case where maybe we would consider basilica or some type of modification therapy before a TAVR, or perhaps even surgery, a complex surgery, if that were to be decided by the heart team. Thank you.
Thank you very much, Dr. Khalique. Getting the scanner in January and being able to get up here in front of you all and tell a story already, quite remarkable. So, the scanner is quite easy to use, and we make sure that you know how to use it. So have no fear. The Alpha hopefully coming soon to a hospital near you. It's my privilege to introduce Dr. Szilveszter now to share his insights with a few months longer than January. So, Bálint.
Good afternoon, welcome everyone. I'm Bálint Szilveszter, cardiologist from Budapest Semmelweis University. I'm going to mainly talk about also on coronaries and heart imaging using the new photon-counting CT. And first, let me thank Siemens for inviting me to give this talk. These are my disclosures. So CT has been established as the first-line test for the evaluation of stable chest pain, with the main indication to exclude obstructive CAD in low to intermediate risk patients. Know that CT has excellent negative predictive value, can exclude significant disease in a large ranges of pretest probability, but specificity is still limited. This is especially due to the heavy calcifications. We saw a rapid increase in the number of CT examinations, also in the US and globally, but some challenges remain the same, even with the newer scanners. These challenging cases include extensive calcification, patients with multiple stents, overlapping stents, mechanical valves, obesity, etc. We heard a lot on the technical details and possible advantages of photon-counting detector as compared to the energy integrating detector. I would just highlight that the photon-counting CT detector with improved spatial resolution and improved contrast resolution can help us with coronary imaging. And also another important aspect is the elimination of electronic noise, which is, as you will see in my talk, is especially important in higher BMI patients. All of these features can lead to an improved diagnostic accuracy, and ultimately for us cardiologists it's also important to reduce possibly the unnecessary invasive procedures. We get actually higher and higher risk patients who try to avoid an early invasive strategy, as it has been shown that CT is an excellent initial test. All of these image quality improvements being complemented by the development of quantum iterative reconstruction technique, as you saw in the earlier presentation. Similar to the lungs and the liver parenchyma, we aim to evaluate the quantitative image quality features, contrast to noise ratio, signal to noise ratio in coronaries. You have two different resolution options, the standard 0.4 resolution and the quantum HD cardiac, which is the 0.2 thin slice resolution. Here you see our quantitative evaluation of the coronaries with the standard resolution. You can appreciate that the CNR almost doubles if you step up to the level 3 and 4 as compared to the FPP images, which is also true for the clinically used 0.4 and 0.6 millimeter slices, and we also evaluated different kernels as slice thicknesses. Here, clinically, we usually prefer BV40 and BV44 for this resolution. Similarly to the previous results, here you see the impact of different quantum iterative reconstruction levels for the 0.2 resolution images. Here we use BV56 and BV44, slightly smoother kernels that in the previous presentation for the evaluation of more extensive calcifications in the coronaries. Here again, we get really nice image quality, and also the higher noise levels that were shown in the previous talk could be compensated by the higher level of iterative reconstruction technique. And as I mentioned, we have less and less problems with scanning obese patients, more obese patients. Here, a patient had a BMI of 36, low image noise was seen on the images, and obstructive CAD could be excluded easily using the 0.4 millimeter reconstruction. But can we translate these image quality findings into clinical value to further improve patient management in patients who were referred to CCT as an initial test? We know that CT is cost effective, it's a has diagnostic prognostic value. Nowadays it's just not merely as an alternative to invasive testing for stenosis assessment. It gives you detailed plaque analysis, quantitative plaque markers. It can combine functional and anatomical information, also can identify the lesion for PCI, helps PCI planning, and could provide additional imaging biomarkers for to refine risk assessment in patients. It is the only non-invasive modality that can accurately describe the extent, location, vulnerability, and severity of CAD, and this is the reason why it has excellent discriminatory value as compared with functional testing as shown in the PROMISE trial. The high temporal and spatial resolution is needed if you want to have an accurate visualization of the extent of the disease, which has been in the focus recently. For risk assessment, we know that extensive but non-obstructive disease is also carries a high risk for adverse events, and this is why we need a reproducible way to evaluate the extent of disease. High-risk plaque features have been shown to also improve risk stratification. Here, an example of proximal LAD lesion, a positively remodeled lesion, non-calcified lesion in the LAD. The detailed anatomic visualization of these features might improve the reproducibility of high-risk plaque feature assessment, which is rather moderate, even between more experienced readers. But more importantly, the implementation of this technology in cardiovascular imaging could improve quantitative plaque assessment, the fully quantitative plaque assessment. These volumetric analysis of CED has been established as the primary outcome of novel pharmacological therapies, such as lipid-lowering therapies, anti-inflammatory therapies, and dedicated software tools can provide you with a set of features such as plaque volume, plaque burden, lesion length, remodeling index, etc., as you see on the right side. Here in the middle, you see high-risk plaque features and non-calcified plaque buildup in a patient who refused taking statins and the RCA. This is an ultra-high resolution image. Forgot to mention. Photon-counting CT can overcome several limitations of plaque analysis, but we do mostly for research purposes and also in clinical trials by reducing the variability in plaque volumes and offering excellent image quality. The high temporal resolution eliminates motion. That helps with the centerline and lumen definition. And also the high spatial resolution improves plaque detection that we use for the Huntsville-based quantification of the plaque. On the right side, you see a calcified plaque on the mesh of the coronary. Early phantom studies showed that the true volume of the calcium is easily or more precisely definable by using the photon-counting technology. And this is extremely important because we want to tailor medical therapy, we want to monitor the changes in coronary plaques, and also might get a better understanding of the natural history of coronary atherosclerosis, as we saw in previous trials. Also, as we heard also that this conference, the non-calcified plaque burden, especially the low attenuation non-calcified plaque burden, seem to have prognostic value, which can be quantified on these excellent high quality, ultra high resolution images, and can be later on implemented into our clinical evaluation. Also, we believe that the radiomic profiling of plaques could be improved by using the photon-counting technology. Focusing on the quantum HD cardiac mode, which I believe helps with the most challenging cases in our clinical routine. Here is an example of patients with a Agatston score of 1,000, almost extensive calcification. Despite this, we have reduced blooming, excellent delineation of the plaques, and we could exclude obstructive disease easily. And this holds also for patients who have most of the calcium concentrated on one segment or one or two segments. Here we have clear lumen definition, even in the severely calcified left main LAD transition using BV56 and quantum iterative reconstruction level 3. Here it has been demonstrated in phantom trials that the reduction of blooming also led to more precise stenosis assessment using photon-counting CT technology, especially for ring-shaped plaques as compared with the energy integrated detector. Colleagues from Zurich, Victor Mergen, and colleagues evaluated the role of ultra-high resolution and the high temporal resolution of 66 milliseconds as compared to 135 milliseconds. And you see, to exploit the full potential of the ultra-high resolution imaging, you need the higher temporal resolution that is provided by the dual source system. This comes with an improved vessel and instant lumen visualization. And we see this also in our clinical routine. Here's an example. Patients were scanned with another vendor's scanner and also the photon-counting CT using the ultra-high resolution or quantum HD mode. Here, only on the 0.2 millimeter thin slices, we could exclude instant restenosis, and also you see the reduction of motion artifacts for this case. Here you can appreciate the difference between the 0.4 and the 0.2 millimeters reconstructions. You see the non-overlapping segment at the distal part of the vessel. Also, you can identify additional abnormalities around the stents. As we saw earlier, in clinical routine, we also tend to use higher kernel numbers. These come with a noise penalty, but you can adjust to this using the higher quantum iterative reconstruction level. In this case, it's level 4, and even in a bifurcational stenting case, we could easily exclude any problems with the stent. This is another example. An RCA shown on the left. The proximal part from the orifice is treated with an integrity resolute stent. Basically, there's no blooming at all. A lumen is easily visible, but there are overlapping stents in the middle portion of the RCA. We detected instant restenosis. This was also confirmed by the invasive angio, and OCT demonstrated a combination of neoatherosclerosis and nointimal hyperplasia for this stent, and it was treated with a drug-eluting balloon. Interestingly, this patient also had a really long stented LAD. 4 stents are seen here. As you can see, even the 2.75 millimeter stent is evaluable. Basically, from the beginning of the LAD to the very distal portion, we could exclude the problems, and this was also confirmed by the invasive testing, and the patient also has an occluded CX. We wanted to see the diagnostic accuracy of photon-counting CT for detecting obstructive CAD, because we saw the excellent correlation with invasive angiography. We wanted to collect our cases and look at more than 50 and more than 70% stenosis, and here are vessel-based analysis results. Basically, the accuracy is around 90. The sub-analysis on the right is for the ultra-high resolution mode. You see that the mean calcium score for the total population was 770, so really high for a stable chest pain population. But one of the most challenging cases are probably pre-TAVI cases. These patients obviously have a lot of comorbidities, extensive calcification, 10-20% of them have stents in the coronaries. Here, photon-counting can add a lot. There are multiple benefits to use, for example, ultra-high resolution imaging for the cardiac and then combine it with the fast turbo flash for the aorta that enables us a fast acquisition of large volumes. And as we saw in the previous talk, you can also use spectral imaging to enhance contrast media in the lumen. A recently published trial showed high diagnostic accuracy even in this challenging population. Vessel-based specificities above for more than 50% stenosis were really high. 88% accuracy was detected. This could reduce possibly the number of invasive angiographies before TAVR, but we can use this tool as well after TAVR. Here in this case, an elderly lady developed atypical chest pain after TAVI. The right coronary artery could not be cannulated. Patient was sent for a CT. Extensive disease is seen on the lower right part of the slide. We could exclude severe luminal narrowing despite the heavy calcifications, but we can also evaluate the TAVI itself. There was no hypoattenuation detected on this valve. Another important feature or territory or aspect that we can get benefits from the higher spatial resolution and improved delineation of calcified plaques is the PCI planning, where we have to select the proximal distal landing zones for a stenting. Also, as you see, state-of-the-art PCI planning was much more than just simply selecting the most severe stenosis. You can combine the functional and the anatomical information to define which lesion leads to ischemia, also provide quantitative plaque assessment for selecting the best tools to intervene, such as in this case in the P4 trials. You will hear about more today. Regarding spectral plaque imaging, we also evaluated image quality using different VMIs. Photon-counting detector uses virtual monoenergetic images as the standard reconstruction method. By changing the kilo-electric walls, you can basically improve image quality. The low-energy images have improved CNR, but more importantly, we wanted to see how it affects coronary plaque volumes using fixed threshold from the literature. We selected more than 50 plaques and evaluated the plaque volumes using the same 3D mask across different virtual monoenergetic reconstructions. And we saw that low energy images from 40 to 70 keV resulted in higher calcified plaque but lower non-calcified plaque volumes. This is extremely important if you want to do plaque quantification with different VMIs. Therefore, the normalizational protocols are needed. And let me walk you through my protocol selection real quick. We have three options for similarly to other dual source system, the flash or turbo flash, the sequential and the helical ones. This is my summary for selecting the optimal protocol for the optimal patients. We start with the calcium scoring. If you have a stents, then we turn on ultra high resolution mode using mostly spiral acquisition. As I said, BV 56 or even higher is used with a high level of quantum iterative reconstruction technique. If you have a patient with a calcium score of 0, low heart rate variability, especially young patients or athletes, then you can do a turbo flash examination. This is around or below 1 millisievert, or you can also easily detect coronary anomalies using this scan mode. Most of the patients will be scanned, however, with the sequential scan mode, especially if turbo flash is not available or calcium score is higher. For patients who has a heart rate less than 70 beats per minute, we prefer diastolic scanning from 670 to 730 milliseconds. And as you see, we either choose the 0.4 or the 0.2 millimeter protocol, or the standard or the ultra high resolution. With the 0.4 protocol, you basically have two options to evaluate calcified plaques. You can use the pure lumen method, which is a material decomposition based method to remove calcium, or you can look at different VMIs, as I mentioned, to better delineate the lumen and the plaque. But if the calcification reaches a certain threshold, which is not set in stone, it's different for every reader probably, or every site, I prefer 300 as a threshold, and we just switch to ultra high resolution imaging. And this is summed up in this slide. Basically, if you have concentrated calcium at 1 or 2 segments, or a lot of calcium altogether, then I would move to the ultra high resolution mode. The helical imaging acquisition is mostly reserved for patients with AFib, ventricular extrasystole. In this case, you see we mostly focus our phases on the systole. And another important aspect is the evaluation of different artificial or bioprothesis or artificial valves. Here you see an example in the middle of a lotus Tavi valve, which has a reduced leaflet motion, and we detected hypoenteric leaflet thickening on this one. Also on the right side, there's a leaflet thickening for a core valve Tavi. One of the most challenging valves is the single tilt disc. Here you see an example of excellent temporal resolution. This patient had elevated transvalvular pressures on the echo. Similar valve opening and angle and areas were detected on the CT, just as with the echo, but the real reason, the underlying etiology for the elevated pressures were only detected by the photon-counting CT, which was subvalvular pannus formation. Thank you for your attention.
Wonderful. Thank you both for wonderful presentations. We do have some time for questions. So if you do have a question, I would ask that...
Can I just bring one thing? I just want to make one comment before I forget, if this thing ever goes down. Sorry. So I think you made up an important which I don't want to forget about the technologists. So our CT manager is here. Mary, raise your hand. And did you start just before we got this scanner? When did you start? Was it just before we got this scanner? 2 days before we got this scanner. And I don't want to discount our CT technologists. They do only cardiac, so they're really good. But there was a lot of support from Siemens on the protocol creation and also the training for the technologists. So within probably 1.5 weeks, we were back up to our full volume of doing 30 scans a day. So I think that's a really important piece of this, and the platform is very slick, and the decision tree, which I don't know if we fully showed, but there's a decision tree aspect which automates a lot of the protocol features, which has been really helpful, I think, to the technologists.
Yeah, very much appreciate that. And so, Bálint showed his great protocol selection, the kernels and the choices, and that looks overwhelming. That's all automated. So it does the selection for you based on those characteristics.
So, hello?
So you guys mentioned scanning in quantum mode. Why would, for certain cases, why would you want to scan in quantum mode for all cases?
Actually, several reasons for that. So you can also think about the dose, so those aspects. If you would do a turbo flash, then it's like 1 millisievert. If you have really diseased, or basically you have 0 calcium patients without any hint that the patients will have obstructive disease, I would just simply do a turbo flash mode if the heart rate allows me to do so. Also, if you compare 0.4 and 0.2 millimeter scanning, 0.4 millimeter scanning has in sequential mode has a larger coverage than the 0.2 millimeter. That's why usually people perform 0.2 millimeter scanning in helical. But this is also like 300 DLPs for having a high resolution image.
And it's also and it's also a lot more data. That's the other part of it, right? It's
Yeah. Go ahead.
Can you scan quantum in perspective or no?
You can, yes.
You
Most
can.
people choose not to.
you can do either.
Yeah.
You can, but it's more steps.
Yeah.
Do you do a calcium score before you choose your protocol?
Yes.
Me too.
I don't know if you heard that. Do you do a calcium score before you choose the protocols? The answer is yes.
Actually, one of the most important.
One of the most important things, yeah. So I mean, the system can say, what is the calcium score, and then choose it. Do they have a stent? Yes or no, and it can automatically direct you to the right protocol.
And the calculation of calcium score is automated in Siemens.
Yeah, calcium score, total and vessel, automated. Yes, please come to the mic.
So I've been trying to sell this photon counting Siemens to the upper leadership in my hospital, and obviously, the cost tag, the difference between a regular FORS and a near-term photon is significant, and a lot of people start like a little sweating when they hear the cost difference. So, and obviously we understand that the pitch is that not only you save patients, many patients, extra trips to the cath lab, but you can also increase the number of patients that are now eligible for CT scans, right? So that's understood within probably those of us who read these CT scans. But how do you have any data and stuff from institutional levels or multi-center institutions that points anything in terms of cost saving to the institution even on a short-term basis or a long-term basis?
So I mean, we don't personally have any data, but I think the cost savings question is more complex than it seems to be, and it's somewhat based locally on how your hospital manages itself financially. So, some hospitals like to avoid diagnostic caths, others don't. So I think you have to really get into it with your finance people of what they're looking at and what helps them to understand the technology more or less. We just went through this because we just are submitting a business plan for another NAATOM. We'll see if they're going to budget it, but I'm going through these same discussions again of why we need another one. So I think from my perspective, a lot of it is locally the way they think and manage finances at your hospital.
It's a very easy argument to say you have a 64-slice scanner, and then you can go to a dual source, and you can do it faster, better, maybe shorten windows dramatically. So it depends on where you're coming from. They can easily do the math from 10 patients to 20 patients a day and see what you get. This is beyond that, right? Because we are, 2 decades into cardiac CT, and this is expanding patient populations, right? Patients of any size, of any calcium score, of any condition can now be scanned. We also saw in some of the things the look at extracellular volume fraction that can be calculated now with this. So if you want to explore those types, that can be moved from MR to CT. And with that, then you free up MR space. So it's really a big picture hospital-based system, but I'm happy to help you work on those arguments anytime. And
sorry, go.
no, I was going to say, I'm glad that you're trying to sell for Siemens. Hopefully you're not trying to get a commission.
I think
Just a
the
joke.
other part of it is marketing, and I think the marketing is real. So we've had patients and also doctors refer themselves to our center. Even doctors who are imagers at other hospitals refer themselves to our hospital to get their scans done on this scanner. Referrings know about it. They want their patients to have the scans here. So I think we've siphoned off cases from a lot of places because of it.
To that end, actually, we all struggle with staffing issues, whether it's readers or technologists and operators. Everybody wants to play with the coolest, newest technology, and we've seen that at a number of institutions where they've been able to attract both readers and technologist staff because they want to be excited about doing what they see as the future, what Siemens sees as the present. But it's quite beneficial that way as well. So how do you quantify that for administration? It's very difficult, but it's real. Well, thank you very much for attending. Really appreciate it. If you have other questions and you're shy, please come up to the front. But thank you, Dr. Khalique and Dr. Szilveszter.